Good afternoon. My name is Steve Mills, and I am Deputy Midwest Editor of ProPublica. We're so glad you could be with us this afternoon for this important conversation. We're going to wait a minute or so for a few more people to join us, and then we'll get started. A quick note that this event is being recorded, and a link to the video will be emailed to everybody who is registered. Closed captioning of the program is also available and can be enabled by clicking on the closed caption option on the bar towards the bottom of your screen. If you'd like to ask a question during today's session, please click the Q&A icon at the bottom of your screen to submit it to us. Okay, it looks like we have enough people to get started. Once again, thank you for joining us for today's conversation. We're going to begin the session with an overview of our reporting, and then we'll be inviting on expert panelists to share more of their expertise. So this reporting took place mostly in 2024, and we wanted to examine how mental health care and insurance companies sort of interacted and some of the barriers and obstacles to getting mental health treatment. Our reporters looked at a number of issues, from the difficulty of getting autism treatment, why clinicians were leaving their networks, to how doctors played a key role in denying health care for people who needed it. I'm proud to introduce you to the members of the team that have been at the heart of this reporting. Team, you can join us on camera right now if you'd like. Today, we'll be hearing from ProPublica reporters Maya Miller, Annie Waldman, Dua El Deeb, and Max Blau.
Great. Annie, you want to kick us off?
Sure. So hello, everybody. Thank you all for joining us here today. As for reporters who you see in front of you, we worked incredibly hard last year to document the pervasive issues that patients and providers face when they are trying to provide or receive mental health care. We're really pleased that you're able to join us here today, and we're excited to share with you first some of our findings from our reporting. So our vision for how we wanted to cover mental health care really built on the work that ProPublica had done the prior year in 2023 on health insurance more generally. Several of our colleagues, including Maya Miller, who is on the panel today, spent many months looking into health insurance companies, trying to understand why patients struggle to access covered care. However, that reporting mostly focused on medical and surgical care and largely did not touch on mental health care. Mental health care really stands apart from other types of medical treatment because, unlike a broken bone or cancer, mental health disorders are not easily identified with an X-ray or a physical test. And thus, the diagnoses and how they are treated are often subject to challenges by insurance companies. We really began our process of looking into this issue by the general reporting process we normally take, interviewing experts and key leaders in the field, examining all the previous reporting and research to find undercovered areas. But most importantly, we wanted to hear from real people experiencing real problems. We scoured the Federal Register for comments detailing issues with mental health care access. We reached out to professional societies. We released a health insurance call out to our readers and our community and received more than 2,400 responses, including hundreds from healthcare providers, patients, and industry insiders. And it was really from the voices that came to us that we were able to develop our first story, which is why I left the network. After hearing story after story from mental health providers who were all struggling with insurance companies and felt that they were jeopardizing their ability to care for their patients. With this initial story, why I left the network, we wanted to provide a flagpole in terms of setting the scope of what we were looking at. I should note that while there are 4 of us here today, here to share our reporting, our team for this story was made up of more than a dozen ProPublicans, a core team of 4 reporters, 4 direct editors, 2 additional masthead editors, a story designer, 2 visual editors, a freelance photographer, an illustrator, a researcher, and a data reporter, among many others across our newsroom. I share this so all of you can understand that there's an incredible network of talented and hardworking people that invest time into each story that you may not realize when you see the final product. I also want to note that it often goes without saying, but it shouldn't. We are well aware of the courage that it takes for people to reach out to us and to share their experiences. And with this project, particularly given the stigma that mental health care and mental health treatment comes with, It's no different. We would not have been able to do this project without learning from the people like you out there what we should really be examining and who should we be holding accountable. And so with that, I'll pass it to Maya to talk about our findings.
Great, thanks, Annie. So yeah, so some of the key findings from our first story, which we called Why I Left the Network, we ended up speaking to hundreds and hundreds of therapists, psychologists, psychiatrists, social workers, and we heard a lot of the same thing, that they wanted to be in an insurance network. They wanted to be able to treat patients and serve clients who from all different socioeconomic levels, but they felt that because of the challenges and roadblocks that insurance carriers placed on their care, that they weren't able to do so and practice safely. And so, this was something that came up a lot in interview after interview. Some other themes we heard about are that insurance companies actually intervened at times with the care that people were getting. So a provider or a therapist would be in a session with somebody, and afterwards the insurance company would say, it looks like you took 60 minutes for that session, but actually 45 minutes seems like it would be more appropriate. And provider said, actually, this patient is suicidal, and that's really inappropriate. And providers said they felt like they couldn't stay in their network and provide the care that patients felt they need responsibly. Some other themes we heard about why people left networks was clawbacks was a common theme. So oftentimes after sessions, insurance companies would go to them and say, hey, it looks like you billed this wrong. You actually owe us tens of thousands of dollars in some cases. And there would be this back and forth, and the providers would say, I don't owe that money, but they would get stuck in this limbo and they wouldn't know if they would have to pull out money or not. And so that made their business untenable. Another common theme we heard from providers was low reimbursement rates. So this was really, really prevalent across the hundreds of providers we spoke with. They said that after factoring in insurance and office rent and having to pay off the loans that they needed to get the degrees to treat and serve these patients, that they actually couldn't even break even. And so it was with a heavy heart that a lot of providers told us that they decided that it was just, they had no choice but to leave the insurance network and therefore leave patients, with less options to care. And I'm going to pass it to Dua, who's going to speak to a few more specific examples.
Thanks, Maya. I think one of the key takeaways from this story is really how much we rely on the public for our reporting. So if this sounds like a plug to all of you to reach out to us with your stories and tips, it is, because we really need you to do our job. And I think that was really evident in this story. So, we heard from more than 500 psychologists, psychiatrists, therapists, and that shaped our reporting. So for example, when you hear the same thing from 130 people, you identify it as a theme. So over and over in our interviews, we heard that providers were leaving insurance networks because reimbursement rates were so low. So one of the therapists told us that, what insurance was paying her barely covered her gas to get to work. Similarly, we heard that, insurers were regularly questioning if care was medically necessary. So, Beth Green said, fresh grief issues like death of a spouse, they would still say things like, when will you be terminating treatment? And I think many people assume that that decision will be up to the therapist who's treating the patient, who's seeing them regularly, to determine that. But what we found is that it's actually insurance companies that often interfere with those decisions.
And then I think we're going to bring in Max, who's going to talk about the next story that he did in our series. We'll give Max a second to sign on, and if not, we can move forward to the next stories and come back to Max. Okay, we will do that then.
Sorry.
Oh, there you are. Sorry.
Sorry
Okay.
about that. I had
No, you're
an
good.
internet mess up. Apologies. So with the the area kind of that my reporting focused on was this concept of ghost networks, which has to do with the phenomenon when health plans list providers who supposedly accept insurance, but who are not actually able to see patients. Once you call down the call the number that's in the provider directory. And to illustrate this concept in a way that really brought the stakes of this problem to life, I focused on a man named Ravi Coutinho, who is a 36-year-old businessman who had struggled with a combination of depression, anxiety, and alcohol addiction. He lived in Texas in 2022, and to get a fresh start, he moved back to a town where he was raised in Phoenix, Arizona. And as a entrepreneur, he bought an Ambetter plan on the health insurance marketplace. He pulled up his provider directory when he moved there in early 2023, and started calling down the list, but was getting, time and time again, either providers who didn't accept Ambetter or could no longer, couldn't see him for weeks or months. He then went and he and his mother tried to call the insurer nearly 24 times, and still could not get the care he sought, in a way that the insurer was supposed to help him with, given the obstacles he faced. Along the way, his health deteriorated. He was hospitalized multiple times, and his health, as it declined, he started to struggle further with his depression and addiction. He could not find the care he needed ultimately, and on Memorial Day weekend, about 5 months after he moved there, he was found dead in his apartment. Following the story that I wrote about Ravi, I zoomed out to try to understand why states like Arizona couldn't stop this issue of provider directory errors. In many states, there are laws on the books that require insurers to clean up their provider directory errors. In spite of those, the errors are still quite widespread in health plans around the country. Our reporting found that most state insurance agencies hadn't issued a fine for directory errors in over 5 years. And when there were penalties, the fines were sporadic. They were few and far between. Over the course of my reporting and about states such as Arizona, experts who we presented our findings to, all agreed that stricter regulations and stronger fines are needed to protect insurance customers from these errors.
Great, thanks, Max. Now we're going to kick it to Annie, who's going to talk about a few other stories that she helped work on throughout the series, or led. Sorry, go ahead, Annie.
We really wanted to understand, how these decisions inside insurance companies were being made. And so we really started from the hundreds of interviews that we did with providers and patients. And one company in particular really stood out, United Health Group and its subsidiaries, United Healthcare and Optum, which manages and insures mental health benefits. We heard from several providers about how they were being subjected to intensive clinical reviews, as Maya was talking about earlier, in which the medical necessity of their therapy was being questioned to the point where coverage might be cut off. Providers often told us it was a mystery. They really didn't know why they were being flagged by United and Optum. But as it turns out, government regulators had actually investigated United for this very practice. By the end of 2021, 3 states had cited the company for using an algorithm system to flag people who they decided were getting too much therapy, and then they were scrutinizing and cutting off care. They were using this process for mental health care, but not physical medical care, which violates federal law. And yet what I found in my investigation is that even after this scrutiny, the company had been able to quietly rebrand this program and is using similar practices in other jurisdictions where they were not cited or sanctioned, which is putting the mental health care of countless Americans at risk. Over the course of our reporting, we obtained leaked documents from inside the company that revealed what is effectively the company's internal playbook for limiting mental health coverage, which helped us better understand the tactics and strategies the company relied on. I think it's important to note that in response to our findings, United Healthcare did tell us that the company remains compliant with the terms of the settlement had with the New York AG and federal regulators. A spokesperson also told us that the process for managing mental health care claims is helping to ensure patients get access to effective and affordable treatment and that they are compliant with federal laws. Maya, you want to go to the next one? So also from these documents, we were able to uncover the company's secret internal cost-cutting campaign that targets what was a growing financial burden for the company, and that's the treatment of thousands of children with autism around the country. In recent years, the number of children diagnosed with autism has rapidly increased, from 1 in 150 kids to 1 in 36 kids over the past 2 decades. You know, experts have largely said that this is due to greater awareness and improved screening of children. But this has also led to an increased need for this kind of therapy, and therefore it's put increased burden on insurance companies and putting pressure on their bottom line. So what we saw in the documents was essentially the company is pursuing market-specific action to limit children's access to treatment. And even though the company acknowledges in some areas of the country there are very long wait lists, it has been, quote unquote, terminating providers from the network, including those who are cost outliers. And it's worth noting that if an insurer drops a provider from the network, patients may have to find a new clinician that accepts their insurance or pay out of pocket, which can be incredibly difficult for families. We, again, I have to note that we did ask questions to United and Optum more than a month, 11 days before our story came out, and they did not respond to our questions, citing the December 4th killing of United Healthcare CEO Brian Thompson as the reason. Move on to the next slide.
Great, thanks, Annie. Now Dua is going to talk about another story. We have a couple more story slides to go, and then we will head to our experts. So Dua, go ahead.
So another story that we did really looked at the role of doctors hired by these insurance companies. So doctors will review cases for insurance companies and often determine whether or not the treatment is medically necessary, and then to decide whether or not to deny coverage if they deem that it's not. But in many cases, based on the recommendation of these doctors, federal courts found that insurance companies improperly denied coverage and violated federal law. And so Maya and I, to do the story, reviewed thousands of pages of court records and insurance documents, and we found that some doctors made critical errors. If the families sued insurance companies, judges in some cases wrote that the insurance companies acted in ways that were puzzling, disingenuous, and even dishonest. But despite these harsh rulings, insurance companies continue to rely on doctors who have been criticized. And so for this story, we focused on the case of Emily Dwyer, who was 15 and severely anorexic when United denied her coverage. She was very sick, and her parents took her to a residential treatment facility to be treated. Before this, she had hid her illness. She flushed food down the toilet. She lied to her friends and family about eating. She would wake up in the middle of the night to secretly exercise. So there's no question that she was gravely ill. But a few months after being admitted, United denied her coverage for residential treatment. Emily's doctors got on the phone with a psychiatrist working for United and explained why she still really needed to be treated. But United still denied coverage, and then it happened again. Her parents knew how much she needed the treatment, and so they were able to pay out of pocket. They burned through their savings, they refinanced their house, and then they eventually sued United. And it took years for the case to make it to the federal appeals court, but when it did, the judges didn't seem to buy United's argument. The company lawyer explained that United's denial came after 3 doctors working for the company had concluded that Emily was no longer engaging in concerning behaviors. And so I'll just let you listen to a clip from where the judge kind of expresses his frustration at that.
You only get to make the decision based on the facts. You're supposed to be making decisions that are in the insured's best interests. And I don't understand how you can.
Maya, are you able to play it?
When it seems to be.
Oh, yes. Sorry, I think I'm having some audio issues on our end.
not true. You say, well,
Is-
oh,
can
you're
you
also
can't
not
hear that?
engaging in any concerning
No, we can't
behaviors.
hear it.
Okay. All right, let's come back to that. Maybe we can try it again later, but apologies for that technical issue on our end. And that leads into the next story though. So Dua and I worked on another story in which actually this woman who's pictured here, Geneva Moore, came to us and was sharing that she had been denied coverage. Her insurer, Blue Cross Blue Shield, denied her ongoing mental health coverage. She was in an intensive outpatient facility. And Geneva's a bit of a sleuth, so she was doing some research and had found that the doctor who was involved in denying her coverage had actually been, his name had appeared in past lawsuits. He wasn't named himself, but his decisions to deny or his recommendations to deny coverage were cited in lawsuits, and that ended up, the judges ruled in favor of the patient, saying, yes, the insurer actually did wrongfully deny things. So Geneva came to us and was like, how is it that this, doctor who has apparently wrongfully denied coverage in the past is continuing to work years later? And in Geneva's case, the physician had cited her progress as a reason to deny. And of course, we're always trying to, create progress in these cases, and the providers wanted Geneva to be doing better before they discharged her, but none of them felt that she was yet ready, and she didn't feel yet she was ready. And in her denial letter, it actually said that through January 18th, she needed the coverage. It was still medically necessary, but on January 19th, she was all better, and she had made enough progress to step down. She felt that this wasn't the case. And so we ended up doing some zooming out reporting, as you can see a theme here, and found that this is kind of prevalent across other denials. And so we worked on crowdsourcing and talking to other patients. We spoke with experts like Dr. Trestman, who you'll hear from in a bit, who helped us better understand that these are really common reasons for denying. And, to Annie's point earlier, mental health care can be a little bit more fluid. And again, this is something that experts told us time and time and again. So while an X-ray can show if a bone is fractured or not, sometimes patients with suicidality, they can improve a little bit one day, and then, the next day they're struggling with something again. And so the idea of progress can be particularly difficult to pin down in mental health care. We also found that insurance companies use these guidelines to behind the reasoning, or, to justify this progress-based denial. So Interqual and MCG are two common guidelines that insurance companies cite when they're saying you've made enough progress. Just something to keep an eye out if you ever come across these insurance denials yourself. We also found, and experts had told us again, time and time and again, that oftentimes these companies can be focused on crisis stabilization instead of recovery. So really just trying to treat a patient to the point where their crisis has been stabilized versus actual true recovery, which is what they're hoping to see with patients before discharge. And now I believe we're just going to quickly talk through some insurance company responses that we haven't yet mentioned. Annie, do you want to go first?
Oh, Max was going to take
yeah,
the first.
Oh, sorry, Max, go for
I
it.
can take this
Yeah.
one. So for all these stories, we reached out to every insurer that we wrote about to get their responses about our findings. And in response to the first story, the Why I Left the Network piece, several insurers said that they were committed to ensuring access to mental health providers, and that their plans were compliant with state and federal law. They also said that the practices to make sure reimbursements rates reflect market value, and they said that they have practices to retain and support providers for their networks. Finally, they said that they are continually recruiting providers. And in response to the Ghost Network, the Ravi story that I wrote, Centene and the Ambetter, which is a subsidiary of Centene, did not respond to my questions or requests for comment. I had to reach out. I tried reaching out to them more than 24 different times and sent them a detailed list of questions.
Yeah, and so I spoke through some of the insurance responses to the playbook stories, but again, United Healthcare told ProPublica that the company remains compliant with the terms of the settlement that they had with the New York AG and the Department of Labor, and said that the process for managing claims is an important part of keeping patients safe. They said their programs were compliant with federal law, and they ensure that people receive the care they need. Related to medical necessity reviews that still are ongoing, they said one type is voluntary and allowing providers to opt out, and they said that that the reviews do not lead to coverage denials. They also said they're committed to working with state Medicaid programs. And again, they said that they're compliant with mental health parity law. And as I mentioned before, with our second playbook story, they did not answer emailed questions that we had.
Great. And two more, and then we'll lead to our experts, and then we'll have time for questions at the end. So Dua, you want to take this?
Sure. So in response to the story about doctors, United, Cigna, Blue Cross and Blue Shield, also that they employ licensed physicians to conduct these reviews, and many of the doctors have to undergo training or have their decisions, reviewed or audited. In addition, a spokesperson for Press, which is an outside review company, said it provides advisory opinions, doesn't usually decide whether or not to terminate coverage. That's usually up to the insurer. And all the companies said that their priority is to ensure that people receive safe and effective care for their individual needs.
Great. And as always with all of our reporting, we always keep an open mind. We went to insurance companies early, and we really wanted to make sure we got this story right. So we included their perspective throughout our reporting. Okay, I'm going to stop sharing, and I'm going to kick it to Annie and Dua, who are going to, and Dr. Robert Trestman, if you want to join us.
So we'll have some time to answer audience questions at the end of the session. Now we're going to turn it over to our expert speakers. So I'd like to invite Dr. Robert Trestman to join us on screen. Dr. Trestman currently serves on the Board of Trustees at the American Hospital Association, chairs the Council on Healthcare Systems and Financing for the American Psychiatric Association, and he's the liaison between these two organizations. He's also the Carilion Clinic Senior Vice President and Chair of the Department of Psychiatry and Behavioral Medicine at Virginia Tech Carilion School of Medicine. Thanks for being here, Dr. Trestman.
It's such a pleasure. Thank you.
We're really excited to have this conversation with you, Dr. Trestman, and we'll start just really broad. What advice do you have for patients who are struggling to access covered mental health care?
This is, simply put, it's a cynical system that requires patients and their advocates to be very assertive about their rights. And that means even though people may be suffering with depression, with anxiety, with other disorders that may minimize their energy, it's really important for them to do everything they can to make the noise necessary to get the care they need and deserve, and usually have paid for.
I have another question. Aside from filing a grievance or dispute with an insurer, what is the most effective way for a consumer of mental health care to hold insurance companies accountable? And not only for providers, how can patients hold their insurance companies accountable?
Well, for clinicians, typically working with our professional organizations, whether it's social work, psychology, therapists, or psychiatrists, it's really important to share your voice with your professional organization to give them the evidence they need to be able to act. Additionally, it's really important to build relationships with your local legislators to make sure, since most of the authority resides within the state and the state insurance commissions, to make sure that people are aware. So building relationships with your elected officials, finding out processes where you can advocate for yourself, both to the insurance commission as well as through legislators, varies depending upon the jurisdiction, but making your needs known is critical. And it's really, look, we've gone through a transformative time over the last 20 years in our society where it is far less stigmatizing for people to be able to say they are grappling with a mental illness or an addiction than it was, making it easier for us to raise our voices, whether as a consumer of care, an advocate for someone, or as a clinician, to work in this way to make a difference. As we reduce stigma, we can overcome the inequities in parity.
And Dr. Trestman, one of the questions that we got a lot in the lead up to this is kind of following up on that last point that you made. What specific role, can patients and consumers play when they're trying to improve access, and what role do the doctors and therapists and providers have?
It's a frustrating situation, but again, a lot of it requires advocacy and sharing information and data. As a patient, a consumer of care, the work that ProPublica has done is absolutely exemplary in terms of telling the story, because stories are what drive human decisions. It's rare that we make important decisions on the basis of data. We usually are driven by our emotions, bottom line. And so it's so important for each of us, when we are in the role of patient, to be willing, wherever possible, to share our story and to push to be heard. So I think that these are the key elements. And we're faced with a lot of challenges in this, because there, as has been mentioned, there are very, very limited financial penalties for the insurers to deny care. They can be inaccurate in the information they share. They can paint with a very broad brush the great work they allege to be doing, even though any formal audit may not support that. So we need to work to actively change the legislative oversight so there are meaningful financial penalties to insurers who are not meeting the requirements of the Mental Health Parity and Addiction Equity Act and meeting their obligation that they have in contract to care for people's needs by paying for the services that they signed up for.
Thank you so much. I have a little bit of a curveball question. I know that none of us have a crystal ball into what is going to happen in the future. And each day for many of us feels like a month, and each week feels like a year. So it's hard to predict what will happen. But do you expect there will be any changes with the new administration that has just come in? Do you think that there will be greater mental health parity enforcement or oversight at the federal level, or perhaps will that shift to the state level at this point?
Again, through my very cracked crystal ball, the images I see are a shift to state authority. But in many ways, that's really valuable, because frankly, mental health law, insurance law in general, other than for Medicare, are driven by states. So I think there's an enormous role for states to play in the months and years ahead, and to really work collaboratively. And it's much easier for us to pull together within a state to make meaningful advocacy, to be able to change the way things are done in a state, as opposed to trying to push for change at the federal level.
I think, you know, your crystal ball might be cracked, but you do have a wealth of experience. Can you tell us a little bit about how you came to your work, and when did you begin to realize that mental health parity was an issue impacting your patients?
That goes back to the last century. When managed care became a thing in the 1990s, and a then CEO of a managed care company told me point blank, I don't care how much people pay us. If I get to write what the medical necessity criteria are, I'll still make money. And that cynicism has not changed in 30 years. And so in our advocacy for care delivery, both for those with severe and persistent mental illness, as well as for those of us with episodic difficulties, depression, anxiety, and so forth, there is no leveler in the playing field. We need to advocate. And so that's not changed over the last 30 years. It is only unfortunately become more obvious as more of us come forward expressing need for treatment, a desire for treatment, and recognizing in a country where healthcare is a commodity, in particular when it comes to mental health and addiction services, it's not treated as a commodity where the supply and demand are in equal amount. I've heard, comments made by the insurers to ProPublica that, they are paying at the fair market rate. Well, the fair market is determined by them. And so they have been underpaying for services that are there aren't enough of us to deliver the care, and they are continuing to reduce the reimbursement in a situation where normally the reimbursement would rise, and it is not.
As you know, we're almost wrapping up, but we have time for 2 more questions. You know, one thing that a lot of people have been asking us about is the mental health parity law. And, you know, obviously the original Mental Health Parity Act was passed in 1996, followed by the most recent legislation in 2008. And of course, there were the updated rules last year. I'm just wondering if you can maybe tell us a little bit about what mental health care access was like for patients before parity, and how you maybe saw it change over time and how you kind of see it moving forward. In this condensed time. We don't have hours.
Oh, basically, I think that the supply has not kept up with the demand. Bottom line, that people, youngsters who need it, children, are presenting with far more complex needs. Adults and those of us who are elderly or over 65 with very complex comorbid medical and psychiatric conditions requiring coordinated care are not receiving that level of care. So we are being faced with a perfect storm where the demand is increasing, the supply is being reduced by a host of reasons, and it's not expected to get better in the years ahead. I think that leveraging technology is a wonderful thing, but we aren't there yet. And telehealth only can shift where the care is being delivered, not expand upon it. And the promise of AI and chatbots is only that at this point, a promise.
Thank you. And you know, we'll wrap up this section of the event just asking you for parting thoughts, Dr. Trestman.
We are at an amazing point in the understanding of mental illness and addiction. Our ability to treat it is rapidly improving with improving medications, enhanced psychotherapies, new interventional approaches. And so in parallel with the reduction in stigma, we are perfectly poised to be able to improve the care delivery to everyone. We have a political and financial obstacle that we need to address and face because we need to redesign the process by which care is delivered. And that is on us as a nation to face, to deal with. And I think we can do that. It's a challenge we can meet.
Thank you so much again, Dr. Trestman, for sharing your expertise with us. I'm now going to invite my colleagues, Max Blau and Maya Miller, to transition our conversation over to our second expert speaker today. Thank you again.
Yeah, thank you, and wanted to shift over to our second expert, Abigail Burman, who is an attorney at Motley Rice, where she represents consumers in litigation against large tech companies. She was previously a Justice Catalyst and Public Rights Project Fellow at Yale Law School, where she focused on the state regulation of health insurance provider directories, as well as regulatory approaches to expanding abortion access. She continues to consult with consumers, nonprofits, and elected officials on both of these topics. Abigail, thank you for being here with us. I wanted to start off with a basic question. You know, the errors that are found within provider directories and contribute to this phenomenon known as ghost networks make it harder for patients to get the treatment they need. Could you touch a bit on talk a bit about how these errors affect access to care?
Absolutely. So these errors manifest in a couple of ways. So the first is that it makes it difficult for you to find a doctor in the first place. So the way that insurance plans work is that they're selling you not only access to a network, but this idea of administrative ease, that you're not going to have to call every single doctor in your town because they will tell you who is and is not in network. And if Dr. Trestman mentioned managed care, if we go back to the 90s and earlier, before the rise of managed care and HMOs, the directory wasn't as important because doctors tended to be in network with as many plans as they could be with most plans, and insurers were really trying to maintain quite broad networks as a selling point. From the 90s onward, and then really accelerating after the ACA, when insurers really picked up on the fact that they could manage their costs by keeping their network narrow, and by effectively denying people care, all of a sudden doctors are not reliably in every plan that you're in. And so this list becomes even more important. And so the first way that they deny care is by just, for people who have urgent health needs, making sure that if you need to see a doctor today, this week, you don't have time to call through the entire directory and find someone where the phone number is right, where they're actually taking insurance, they're actually taking new patients. And so there's just this urgency factor where people don't necessarily have time to do the administrative work that you need to do when the directory is wrong. And then there's also the exhaustion factor, where even if it's not necessarily an urgent condition, doctor's offices are open from 9 to 5, if that. A lot of people work during those hours or have other responsibilities during their hours that mean that they can't make calls. Or because you are sick, you are tired and you don't have the energy to make those calls, or you're also dealing with caring for other family members and loved ones. All of these things that mean that you just don't have time to absorb the work that the insurer should have been doing of making sure that this directory is accurate. So kind of the two facets of how we see these directories pushing off access to care. Another one is the financial hit. When it's hard to tell whether or not a provider is in network, it puts people at risk of receiving unexpected bills. If you go to a doctor you thought was in network and is actually out of network, and you really only have to receive one unexpected bill for multiple hundreds of dollars before you become a lot more hesitant about going to the doctor the next time, because you just have that knowledge that you can't be sure it's not going to happen again.
And from our conversations over the past year, one of the things that you shared with me is that your interest in Ghost Network started with your own personal experience. What happened, and how did this experience lead you to want to get into the research of ghost networks?
So I started looking at this issue because I had moved to a new state for law school and couldn't find a specialist. I called through like 10 or 15 entries in the directory, got a bunch of answering machines or dial tones, and no one ever called me back. I eventually found a doctor through like a referral from a friend. But I had worked in health policy before law school and had seen an article talking about ghost networks as a real public health danger, that if people can't find a doctor, they cannot get the care that they need. But I realized that no one had ever really talked about this from a legal perspective and thought about it not just as a public health issue, but also as a really severe consumer protection issue. That when we're talking about ghost networks, we're really talking about a classic form of false advertising. You are being promised something and you are paying for that promise and you are not receiving it in return. There wasn't a lot of literature grappling with it on that level, or talking about, we have this massive issue. What can we actually do to fix it? A lot of states had passed laws in the wake of the ACA in like 2014 to 2016 to try to tackle ghost networks, but no one had really looked to see if they were working. And unfortunately, my work found that they really weren't. As I think Max has experienced, it's one of those issues where it's so basic and it's so foundational to everything that happens in the healthcare system that once you see how often these directories are wrong, it just becomes kind of an obsession very quickly, because it is this foundation that so many other things, from public health to the way we enforce other regulations, rest on. And so here I am now, I think, nearly 10 years later, still talking about this issue.
Thank you so much for sharing that. Super helpful to understand. And so, given that you found that it's pretty broken, I see in the chat, we have people writing in with their own healthcare experiences and insurance issues. What can people do to try to increase access to healthcare if they're finding these ghost network issues? You know, what advice would you give someone going through this?
So, first of all, I'm sorry. It is incredibly frustrating, and it's a problem that arises when you are least equipped to deal with it. So the answer I always give is you have to complain. And you're going to have to complain in a way that often we've been socialized to think is bad. You know, you're gonna have to take the response that you're being given by the insurance company and say, no, that's not good enough, and really stand your ground, and trust that even if you feel like you are being unreasonable or a jerk, you are not. You are just asking for what you are entitled to by your insurance contract and by law. So the kind of Max has written a longer guide to how to do this, but the first step is to complain to your insurer. And so file a grievance. Of insurers call it by different names, which is one of the many reasons this is so difficult. There's nothing really standardized, but you want to file a grievance and basically just say, I have tried to call, 5 to 10 doctors usually does it. No one is picking up. No one is actually taking new patients. I cannot find care. But I would also add, don't let the complaining stop there. There are a lot of people who have responsibility for healthcare. So your state will have an insurance regulator. I would recommend also complaining to them. If you are in a Medicaid plan, your state may also have a separate regulator for Medicaid specifically. Complain to them. You have 3 layers of elected representatives. You have local, state, and federal elected representatives. Call all of their offices, tell them what's going on, and see if they can help. At least when we're talking about state regulators, I think people can assume that they're just kind of shouting into the void, but these regulators get very, very few complaints every year because unfortunately, it's just, no one wants to make another phone call when you've already made so many to doctors. It just feels like more work. But I promise you, because they get so few phone calls, it takes very little to move the needle and start an investigation. Like single digits numbers of complaints can be enough to kickstart serious state enforcement action. So calling to complain really does matter. And then I like to, every time I've complained to a new body or person, then circle back with the insurer and give them the complaint number, tell them who you called and when, just so they're seeing that you're not dropping this, that you're aware that you have rights, that you are entitled to care. And hopefully, you're just trying to keep pushing it up the chain until you get to someone who can actually solve your problem.
Thank you so much for sharing that, Abigail. So it sounds like squeaky wheel approach.
Squeakiest.
Yeah.
Yeah.
Got it. Well, thank you so much for sharing your expertise with us and for answering some of those questions. We're now going to welcome back the rest of the crew. So Steve, Dr. Trestman, Annie, and Dua, if you all want to join us, and I will kick it over to Steve for the audience question and answer portion.
Thanks very much, Maya. That was fascinating. Dr. Trestman and Abigail were both so interesting. I learned a ton. Even after having edited some of those stories, I learned so much. I'd like to share a link to our event survey in the chat box. We hope you will take the survey. It helps us improve these events and learn from what you are seeing and hearing from us. I want to thank everybody for all the questions that have been submitted through registration. We've received a lot of questions and we may not be able to get to them all, but we're trying to ask some and answer some that get to some of the larger themes here. Our first question, I think, is for Max and Maya, and I think it takes, there's a jumping off point from what we've been talking about. Aside from filing a grievance or a dispute with an insurer, what's the most effective way for a consumer of mental health care to hold their insurance company accountable? One of the things we talked about was in the Emily story, that she filed a lawsuit, and that's a hard thing for everybody to do. So I wonder if you can talk a little bit, Max and Maya, about how we can hold insurance companies accountable.
Thanks for that question, Steve. I think addressing the ghost network portion of this, I think Abigail touched on several key points in this. And as she noted, we have a guide for how anyone who's experiencing ghost network issues can um, do as what Maya and Abigail both said, be the squeakiest wheel. But I think a few things beyond a grievance that you can do is if you have called your insurance company, filed a complaint, and all of that's not working out, you can, talk to lawmakers who are, working with insurance companies. That's one additional place that you can touch, you can do, but and you can be public, in your in making your making your voice heard. And one thing Abigail mentioned to me in our conversations over the years or over the past year was that your superpower is not going away, and your strongest weapon is just to kind of keep being persistent, even if it takes up time and energy to get the care that you need. Maya, did you want to add anything more about the claims and kind of the treatment portion of that?
Yeah, I'll just quickly, this is going to echo a bit of what Abigail and Max just said, but something that we learned through doing this work is that during the insurance process, if you receive a denial of coverage, or if you get a explanation of benefits where you owe a bit of money more than you thought you did, you can file for a claim. So you could say, I want all my claim files. You can file for your claim files from insurance companies, and that you have, under the law, you have a right to access all of the internal documents that the insurance company has produced when deciding whether or not to cover your care. And those can be extremely illuminating, and they can be a first step in an appeal process, and they can help you draft an appeal. So we actually drafted and created up this claim file helper where you can fill in the denial information, and it spits out a form for you to send to your insurance company, and then you get all that information back. So I just want to flag that as a first step, as if you ever get a denial, is usually a good first thing to do. Steve, back to you.
That's very helpful. Annie, this question is for you. Have our investigations included the impact on seniors who have Medicare, and which, if I'm not mistaken, isn't covered under the parity law?
Yeah, well, unfortunately, this response will be pretty short. Specifically, we did not focus on Medicare in our investigations. We did look at Medicaid, however. That said, this is a really important point. Medicare is not covered by the Mental Health Parity Act. It is actually carved out of the Mental Health Parity Act, which is such a surprise because so many people in this country get access to health insurance through Medicare. So you would think that these protections would extend to that type of insurance. I think that there is a huge opening for reporters such as ourselves to look into this and to follow up on this. And the reason why I wanted to flag this question was because we want to continue to look at this. So if you are having issues with Medicare or Medicare Advantage and mental health, please don't hesitate to reach out to us.
Dua, this question is for you. Is there anything mental health providers or therapists can do to help clients or change the system for the better? We've talked a little bit about what patients can do. What can therapists or health providers do?
Well, I think for starters, helping their patients better understand the system and reminding them that they can appeal the decision if they feel it was improper. What we know is that most people don't appeal. I think one study found that consumers appeal less than 1% of denials. So I think there's this, almost this acceptance that if an insurance company is denying coverage and that is just, that is what it is. So I think maybe, talking to their clients about, the appeal system, helping them understand how that works. And I think we've also heard from providers that, talking to lawmakers, making them aware of the challenges that they're facing has been fruitful. Also working with their professional agencies to show that this is a problem that, not just one person is encountering, but it's multiple people in the field. I think as Dr. Trestman had said, that absent federal changes in the law, some states have taken it upon themselves to reform legislation.
And that I wanted to ask a little bit more about that for Maya and Max. Are there any states that are investigating and holding insurance companies accountable, or is it happening on the federal level?
In regards to ghost networks, there are several states that are attempting to do that, including New York and Massachusetts are two examples where prosecutors have attempted to do so. However, one of the shortcomings of the way health insurance regulation works is that while they could bring actions, about past issues, state insurance regulators are often not doing the work, even though it falls under their purview in that regard. Maya or Annie, did you want to talk a little bit about how this looks on your side of your reporting?
Sure. So Maya and I actually did a story where we looked into all of the laws in all 50 states to determine how some are trying to chart new paths to secure mental health access. And many of these protections are only starting to be enforced, but many states have actually begun to punish companies for violations and force them into compliance. One example of this is insurers generally face very few limitations on how they define mental health care as medically necessary. They often create their own internal standards instead of relying on ones developed by nonprofit professional medical societies. And then these standards can be used to challenge diagnoses or treatment plans. So California, which is really kind of one of the trailblazers in this area, the legislators there passed a robust law in 2020 that became one of the first laws in the country to require, on a state level, to require the use of nonprofit guidelines to make decisions. The law generally requires generally accepted standards of care for mental health and substance use conditions, and it forces insurers to rely on evidence-based sources that establish a criteria. They also bar insurers from covering only treatment of short-term or acute symptoms, such as crisis stabilization, rather than the underlying condition. And so if you look to states like California, many other states have actually started to follow suit. You can read more about this in our story. Maya, do you want to add anything else?
I just wanted to go to the federal level for a bit. So the Department of Labor is responsible for overseeing health insurance plans provided through employers. There are some exceptions, of course, but for the most part, that's the case. And so there's a law passed in the 1970s, ERISA, the Employment Retirement Income Security Act, that describes how the Department of Labor has oversight over health insurers, what the laws are, what regulations they have to follow. In past reports to the Congress, Department of Labor has asked for stronger enforcement tools because they've said, because of the law, they can't actually have enforced punitive damages on insurance companies. So when they're investigating companies, they can recover the amount of money that the insurance company should have paid out. But they can't say, oh, you actually wrongly denied this coverage, and so you're going to have to pay a fine. And so that's something that the Department of Labor has been flagging to Congress and asking for stronger enforcement tools. They've also been asking for more staffing. And so on the federal side of things, the Department of Labor, the division that oversees health insurers, have initiated a number of investigations, but in interviews with them and in their own reports, they've flagged that they're just not, they need more enforcement power to really hold insurers accountable.
Dr. Trestman, I have a question for you. Is anybody developing models of mental health treatment outside of insurance that is more transparent and less profit-driven?
Well, there are so many different therapists and many psychiatrists, psychologists who are not seeing patients in an insurance environment. It's purely fee-for-service, direct pay. And so this is what's happening in the real world, where many people, if they have disposable income, and sadly, even if they don't, are getting access to care by paying directly out of pocket, avoiding insurance, even if they have an insurance policy. So this, along with many online companies trying to offer direct to consumer care, is a new venue that's yet to be proven, because almost all of those are for-profit companies.
Thank you very much. That is it for our time today. I want to thank our panel for the insightful discussion, as well as our audience for joining us and for your thoughtful questions. Again, this event has been recorded, and you'll receive an email with the full video of today's discussion. A link to our event survey will also be added to the chat box. We appreciate your feedback, so we hope that you will take the survey. From all of us at ProPublica, thank you for joining us and have a great evening. We look forward to seeing you next time.